Association leadership for giving us this opportunity where we can discuss this rare subspecialty to all of you through various academic forums. This year's onco subspecialty comprises of me, Ashish Gulia, as the chairperson. Along with me, we have Dr. RR Saggar from Punjab and Dr. Suman Byregowda from Karnataka, both very eminent practicing ortho surgeons from the country. To guide us, we have Dr. Mayal Natrajan and Dr. Ajay Puri as our advisors, and everybody know them pretty well. The mandate this year is to reach our young colleagues at various multiple forums, and this is what we have proposed to IOA administration, and I'm thankful that we have got complete unconditional support from them. In this webinar series, we will be having 4 webinars which will cover various aspects of bone tumors, and it will be happening on every alternate months from now onwards. The first webinar today is giant cell tumors, and similarly we have one on non-surgical management of benign tumors, then we'll have on malignant bone tumors, and then on pathological fractures and metastatic bone disease. Similarly, we are very thankful that IOA administration and executive committee has given an approval to Sarcoma Education Foundation to be the academic partner for the monthly webinars which Sarcoma Education Foundation is doing on every second Saturday of each month, where we are covering the entire basics of musculoskeletal oncology in 12 sessions, where we have few didactic lectures followed by case-based discussions, and then a very interesting quiz and prizes to be given. So with this platform, I would like to encourage all our juniors, postgraduates, and young orthopedic surgeons to join those webinars on every second Saturday of each month in the evening at 5:30 p.m. We are also making efforts to reach to each and every state to organize various orthopedic oncology related activities, whether it's standalone CMEs, workshops, or as a part of their annual or mid-year meetings. We are also finalizing a few cadaveric courses in this year, and I'm sure we will again get support from IOA administration for conducting these courses. So without any delay, I would like to invite our first speaker in this webinar, where theme is how do we manage giant cell tumor of the bone in most effective way. To start with, we have Dr. Srinath Gupta from Hyderabad, a practicing orthopedic oncosurgeon, who is going to talk us about the importance of biopsy in management of giant cell tumors and how to do a biopsy correctly. Srinath, all yours.
Yeah. Thank you, sir. I would like to thank IOA and Orthopedic Oncology Subcommittee for giving me this opportunity. So I will be talking about how we do a biopsy, and mainly talking about giant cell tumors of the bone. Just a second. So yeah, today's theme is giant cell tumor of the bone, as we all know, commonly seen in 20 and 40 years of age group, and they're rarely seen in pediatric age group, and also at times seen in adults over 65 years. And the radiology is typically well-defined lytic lesions. They are eccentric in location and extend to the subchondral locations in the bone. So now, if the radiology is suggestive of a giant cell tumor, is a biopsy mandatory? And if you are doing a biopsy, what is the planning and how we do a biopsy is what I'm going to talk about. Now, this is a 22-year-old male. If you can see the radiology, it's a lytic lesion involving the distal tibia. It's eccentric in location, expand side, and fairly well-defined margins. Do we do a biopsy here? So the operating surgeon thought it looks like giant cell tumor, and he went ahead, did a curettage, cementing, and 6 months post-surgery, the patient presented back with local relapse. So the surgeon had a doubt that he might have missed something, and he got a PET scan done. PET scan showed multiple lytic lesions elsewhere. And then a biopsy was finally performed. It was reported as osteosarcoma. If a biopsy was done before the first procedure, it would have been managed differently, and the patient would have been treated differently. Now, this is again a 25-year-old male, again a lytic lesion, eccentric in location, well-defined margins. If you look at this, it looks like a benign lesion again, but a biopsy is suggestive of a chondroblastic osteosarcoma. So even though the radiology is suggestive of giant cell tumors, these are the various differentials that we need to keep in mind when we're dealing with a lytic lesion in the bone. So the differentials can be a chondroblastoma, can be multiple myeloma, variants of osteosarcoma such as telangiectatic variant or a fibroblastic variant. It can also be clear cell chondrosarcomas. And because each one of it is dealt with differently, so it is very essential to arrive at the correct diagnosis before we start treating. Now, how do we arrive at the correct diagnosis? The answer is biopsy. So in the next few slides, I'll be talking about the principles of biopsy. A biopsy is very essential because a biopsy will help us differentiate between a benign lesion, malignant lesion, a degenerative lesion, and also an infection. And what are the prerequisites before doing a biopsy? We need to have a full-length MRI of the bone so that we don't miss any escape lesions. And that is when we have to plan a biopsy. Now, who should be performing the biopsy? Biopsy should be performed by or under the supervision of the surgeon who will be performing the final surgical procedure. And before performing the biopsy, the person performing the biopsy should have the following answers already in his mind. 1, the probable diagnosis. 2, the exact extent of disease, which will be given on an MRI. And also the final operative plan if his probable diagnosis is correct. So when we plan a biopsy, if the radiology suggests a benign or a malignant lesion, the planning, the entire process remains the same. Because unless and until we get a histopathological confirmation, we don't know whether we are dealing with a benign lesion or a malignant lesion. So now these are different types of biopsies that we usually do. It can either be a closed needle biopsy or an open biopsy. In closed needle biopsies, we have fine needle aspiration cytology or a core needle biopsy. As we all know, there is no role of FNAC for confirmation and diagnosis of bone and soft tissue lesions. When you talk about core needle biopsies, it can either be a true cut biopsy or a J needle biopsy. True cut biopsies are done for soft tissue lesions and a J needle biopsy is done for bone lesions. When you talk about open biopsy can be an incisional biopsy or an excision biopsy. So in the next 2 slides, I'm going to talk about the differences between a closed needle biopsy and an open biopsy. As we all know, when we are dealing with, when you're operating on a sarcoma or a bone tumor, it is always advised that the biopsy tract is excised in the final surgical procedure. Now, this is the example of the biopsy tract excision compared to a closed biopsy and an open biopsy. In a closed biopsy, very small amount of skin is excised compared to an open biopsy where more soft tissue is excised, more skin is excised, and at times it might need plastic surgery free flaps for closure. The other advantages and disadvantages being in an open biopsy, we get more tissue and the chances of negative biopsy are less. But the disadvantages are the incision is larger, the risk of contamination in the soft tissue is higher, it's a general anesthesia procedure, the risk of pathological fractures are higher, and because the patient needs admission and general anesthesia, the cost of the entire procedure goes up. And when compared to a closed biopsy, the advantages are it's minimally invasive, the amount of contamination in soft tissue is less. It can be done under local anesthesia in your OPD, and it is cost effective. But the only disadvantage being the risk of negative results is slightly higher. So you need to plan your procedure well, and then you have to make sure you are away from the neurovascular structures. So always, whenever feasible, a closed biopsy is advised. And whenever you're doing a biopsy, these are the things to avoid. We have to avoid intercompartmental planes like if you're dealing with a lesion in the proximal humerus, we should not go through the deltopectoral groove. We have to go through the anterior 1/3 of the deltoid. We have to avoid major neurovascular structures. We should not enter through the normal compartments, always enter through the affected compartment. And whenever you're doing a biopsy, we have to avoid heavily calcified or ossified and necrotic areas. So there are specific indications for an open biopsy, such as when you need more material to run molecular or genetic analysis, or when repeated close biopsies are not giving you a representative diagnosis. As in radiology suggests to something else and the pathologist calling something else, it's always ideal to give your pathologist more material and to confirm the diagnosis before you start treating the patient. And if an open biopsy is being performed, these are the things to avoid. You have to avoid transverse incisions. The incision should be along the line of the final surgical procedure. Again, major soft tissue and neurovascular structure should be avoided. Like in this case, the surgeon went through the rectus anteriorly. We should avoid biopsying through the joint. If we do a biopsy through the joint, we are contaminating the joint and the patient may need an extra arterial section. And if you're putting in a drain, drain's exit should be along the line of incision and should not be away from the incision. And during the surgery, never raise flaps, go directly to the bone, take out samples, and while closure, achieve perfect hemostasis. And when you've taken more samples from the bone, make sure you give adequate splintage to the bone to avoid pathological fractures. The images here show different approaches for different lesions in the bone. Like in the proximal femur, it has to be through the lateral aspect. Again, femur shaft, lateral, distal femur, it can either be medial or lateral based on the disease. If it's proximal humerus, has to be anterior to the anterior 1/3 of the deltoid. Humerus shaft, again, lateral. If it's proximal tibia, it can either be medial or lateral. Fibula, again, bang lateral because it's subcutaneous bone. So this is the typical armamentarium that we would need when we are doing a biopsy. We'll need a Jamshedi needle, a surgical blade for an incision, local anesthesia to give before doing the incision. So in this video, I will be talking about how we do a biopsy for a solid lesion. So this was a 3-year-old boy, came to us with thigh pain. So lesion was involving the femur diaphysis. So patient was given anesthesia, and then this would be the final surgical procedure, incision. So even though after giving anesthesia, we always give local anesthesia, and then we start the procedure. That's a small stab incision that we take, and then J needle was pushed inside the bone. Once it's inside the bone, we remove the stellate, and then we take out adequate cores from the bone, and then the J needle is excised and the samples are collected. So at least 5 cores of 1 centimeter each are collected, and the sample should be sent in 10% formalin. So that is what we do usually for solid lesions. But when it comes to lytic lesions or giant cell tumor in particular, wherein the lesion is not solid, there is some soft jelly-like material inside, the procedure is slightly different that we would advise. So this video shows that. So this is a 35-year-old male who had come to us with complaints of pain in the knee. Radiology showed lytic lesion involving the proximal tibia. MRI showing lesion in the proximal tibia. And the lesion is involving only the lateral aspect. So that is where the incision would be. So the lateral aspect, that is where we tried to do the biopsy from. Again, the approach remains the same, aseptic precautions. We given local anesthesia. Once anesthesia is given, you put in a stab incision, and then you insert the J needle. So in a lytic lesion or in a giant cell tumor of the bone, once you go in, we do something called a piston movement, in-out movement that will fill up the J needles canal, and then you start getting material. So once the material is all procured, you have to put it in formalin and then send it to your pathologist. So it is very important that you send it to a experienced pathologist who sees bone and bone soft tissue sarcomas in general in routine, because If it's someone who is naive to bone tumors, you might end up getting a report something like this. And as we all know, bone tumors and mainly sarcomas are heterogeneous. Some areas may be low grade and some areas may be high grade. So whenever you're doing a biopsy, the entire material has to be sent to only one pathologist. And if you want a second opinion, you have to collect material from that one single pathologist and send it to a second pathologist instead of dividing the material and sending it to two different pathologists. So I would like to conclude my talk by saying whenever you have a suspicious bone lesion, after adequate imaging and clinical examination, always do a biopsy before you proceed further. Thank you.
Thank you so much, Srinath. It was nice and crisp. So, Srinath, before we go further, I have one question for you.
Yes, sir.
How difficult it is to biopsy giant cell tumors as compared to other malignant tumors like osteosarcoma or Ewing sarcoma? Many
So
times people
difficult.
say that it is just blood and we are not able to biopsy them with a needle.
Right, sir. So as I showed in my video, it is very important that once you go in, you do the pistoning movement and also you scrape the walls. You scrape along the lining of the walls and make sure you get adequate material, because as soon as you put in the J needle, what we see is all blood, but there is some minute elements that are seen in the blood as well. But to make sure we get adequate material, we have to go around in the entire cavity. If needed, you can take image guidance and then make sure we are targeting all pockets, all areas in that cavity, and then that will give us adequate material.
Okay. Requesting you to please stop sharing so that we can move ahead.
Sure.
Okay. So now next, it is my pleasure to invite a dear friend and last president of Indian Musculoskeletal Oncology Society, Dr. Mandip Shah. Dr. Mandip Shah is a very eminent orthopedic oncosurgeon based in Ahmedabad, and he is going to speak to us on various kinds of issues which are related with curettage for giant cell tumor. Mandip, all yours.
Thank you, Ashish. I hope I'm audible.
Yes, if you could do this full screen, it will.
Yes, I will do the full screen. All right. So thank you, Ashish. Thank you, Dr. Thakkar. Thank you, Suman, and thank you, IOA, for having me here. Always nice to be with friends, whether online or offline. And what a better time than be on a Sunday evening. So welcome all of you. I've been given a task of talking about when to curate or excise a giant cell tumor and what is the role of adjuvants, meaning by surgical adjuvants when we are doing an extended curettage of a giant cell tumor. So I'm going to first talk about various tips and tricks of curettage, and the answer to the first question, when to curate or excise, is it will be self-explanatory, or that answer is hidden in that particular minute intricacies of that first part of the discussion. So GCT of bone, I'm first going to talk about what are the tips and tricks of an adequate curettage. We all know that GCT is a disease of young individual, and these are the diseases which happens in the periarticular area. And that is why the ideology or the philosophy of the treatment is to preserve the joints, because we are actually dealing with a benign tumor. We are not dealing with a malignancy. So we want to do more function preserving intralesional surgery rather than doing a resection. But when we do an intralesional curettage, that means we are scooping out the disease with a curette. The advantage is that you are preserving the natural joint, but the trade-off is that we leave behind microscopic disease. And if you look at the older literature, if you go back to 90s and the literature before that, you will find that the local recurrence rates are reported as high as almost 55-60%. Vis-a-vis, if you do an excision, you are doing a complete removal or en bloc removal. You are actually taking out all the disease, reducing the chances of recurrence to almost negligible. But at the same time, we are losing a joint, so the patient will end up in either a megaprosthesis or a fusion. And these are all very young individuals who are going to live for another 50 years. And that is where we have to see what is a better for that particular patient. As I said, if you look at the older literatures, the chances of recurrence in those literature is reported as high as 50 to 60%. But if you look at the recent literatures, the chances of local recurrence have come down to less than 10% in majority of the fresh series. And what has caused this improvement is that the conventional curettage is now out, and what we now do is extended curettage. So what is an extended curettage? Extended curettage meaning by you don't make windows, you're making a large door which gives you a 360-degree vision. Then you use variety of scoops, and you use mechanical, chemical, and thermal adjuvants to reduce or minimize the residual microscopic disease, hence reducing the local recurrence rates. So what are the adjuvants that we are talking about? We can have mechanical adjuvants like high-speed burr, chemical adjuvants like phenol, alcohol, hydrogen peroxide, or methyl methacrylate. And we could also use thermal adjuvants like electrocautery, bone cement, argon beam, and liquid nitrogen. So before, so the first step for an adequate or an efficient curettage is to make a good window. So what precautions we should take before making the window, and how large should be the window? That is the first question. So before you make the window, you should cover the surroundings with a hydrogen peroxide soaked gauze basis, so that whatever spillage or the disease spillage happens, that doesn't contaminate the surrounding tissue. We come across a lot of patients treated elsewhere where these kind of precautions were not taken, and they present with multinodular recurrence all around in the soft tissue. That is because of the spillage which was not contained using gauze basis. So it is very important that the surroundings are covered with hydrogen peroxide soaked gauze basis. So this is how you typically do, and especially in the dependent part, so that whatever spillage happens is contained in that gauze. If you take this particular case, there is a giant cell tumor biopsy proven in the medial condyle of the femur. When you make the window, it should give you an adequate exposure of 360 degrees. So when you make this kind of a large window, then only you can do a proper curettage and do a proper reconstruction. Whenever you're making a window, make sure that all these extra articular cortices which have been ballooned out or infiltrated by the tumor, that can be safely removed, should be removed. So at the end of the window, making a big window, all the walls or the borders of the window should be very, very sharp. Of course, whenever there is a cartilaginous area which is also involved by the tumor, you cannot take out that part, but whatever is extra articular cortices, that can be easily removed. So if you look at this particular patient with a large extra osseous Campanacci 3 type of disease, as you can see, there is a large expansion of the lateral cortex and the posterolateral cortex, which you can easily remove. So when you make a window, at the end of the making window, all the walls or the borders are absolutely rigid, and there is no soft ballooned or infiltrated part of the cortex which has been left behind. Whenever you have this kind of septas, you have to remove those septas, because septas have happened because of the tumor infiltration underneath and above it. So unless you remove the septa and convert it to a unilocular cavity, you are likely to leave behind disease underneath the septas. So the length of the window should be big enough to expose the complete supra-inferior extent of the disease, and it should give 360-degree vision to the surgeon. Coming to the use of high-speed burr. So whether we should use, what advantages are there for using high-speed burr, what RPM is optimum, and whether a simple burring via drill is sufficient or not. If you look at this particular pre-burring cavity, and you look at this post-burring cavity, if you look at this post-burring cavity, you will see that there is a stark difference in the look of these two particular cavities. That is because whatever your mechanical burr can do, whatever your high-speed burr can do, your mechanical or handheld instruments like Curette can never do. And in this walls, whatever this blackish tissue you are seeing after the primary curettage, they are all infiltrated by microscopic disease, and unless you remove this microscopic disease, there won't be you will leave behind a microscopic disease which will increase the chances of local recurrence. If you see this pre-burring and post-burring cavities, you will see what am I talking about. And typically the burr that you use should have more than 35,000 RPM of speed, and you should preferably use new burr points every time during the surgery. And all my friends will agree, and as the world agrees, and that burring is an integral part of curettage, and it is no more considered as an adjuvant. Unless you are able to do a proper burring, you will not be able to do a proper curettage. And the cases where you cannot do a proper burring are actually a contraindications for curettage. So now I will go back to the first question, that what are the so that will answer your first question. So whenever you cannot do a burring like this, you should not do a curettage, and that patient will undergo a resection. If you look at the literature, this paper talks about patients who undergone curettage where only burr were used, vis-a-vis burr and other adjuvants are used, and you can see there was no difference in the recurrence rates, or the burr was absolutely suitable. I am as efficient as burr and other adjuvants. This paper looked at curettage versus resection and their recurrence rates, and they concluded that whenever a burr was used, high-speed burr was used, the local recurrence rates were almost as many as the resection group. So these patients, if you use a proper burr in a properly selected case, the chances of local recurrence are almost as less as a resection counterpart. So that brings me to the first question: what are the contraindications of curettage? So basically, if you have these kind of patients where there is large soft tissue component, you will not be able to use high-speed burr. This patient should not undergo curettage. Similarly, if you have a cortical break with soft tissue component more than one tissue planes, you cannot do a proper curettage here. Similarly, here there is no cortical bone to support the reconstruction. Forget about even after curettage, you cannot do any reconstruction here. So you should not do a curettage, you should do resection. Similarly, these patients have pathological fractures in multiple tissue planes. Again, you cannot neither do a proper burring, nor do a proper curettage, nor do a proper reconstruction, and that is where you should not do surgery, curettage for this kind of patient. This patient should undergo en bloc wide excision. Again, if the patient's articular cartilage is already damaged, or patient already has a pre-existing osteoarthritis, doing a curettage will always leave behind an unsatisfactory patient, unsatisfied patient, and unsatisfactory result, because these patients will always have painful knee or painful joint. Patients who are present with giant cell tumors of expandable bones like proximal radius or proximal fibula or distal ulna or a sternum or clavicle, these are the expandable bones where even if you resect the bone, the patient's functional outcome there is no difference in the patient's functional outcome, and that is where, to be on a safer side, we usually resect these kind of patients. So basically, patients who have good, free, relatively painless range of motion at the neighboring joint, the articular cartilage is healthy on imaging, there is no pre-existing osteoarthritis. The cortical bone is good, it is present all around, which will allow a mechanical burring, and adequate structural stability is left after curettage to support the reconstruction. These are the patients where you can easily or safely undergo curettage, and these patients should undergo curettage. So basically, presence of a soft tissue mass or a pathological fracture or a recurrent case is not a contraindication for curettage if the other criteria are possible, are case matched. Coming back to the thermal adjuvants, we have electrocautery, argon laser, and liquid nitrogen available to us. If you talk about electrocautery, it causes coagulative necrosis of tumor tissue, and various papers report the literature reports the recurrence rates between 0% and 12.5%. We have electrocautery in every operation theater. We put them on spray mode, and we put it on 100 or 100 plus power, and then each and every millimeter of the cavity is usually electrocauterized like this. When you talk about argon laser, it is not available everywhere, but the advantage of argon laser is that its throw is better, its throw is longer, it gives you a better vision, and the charring is much less. However, because of its prohibitive cost, it is not available to many of us. I personally feel that patients where there is deficient cortices and where like this patient has a posterolateral deficiency of the cortex, these are the cases where you cannot use burr in this area, and this is the case where using electrocautery will be of immense help. Coming to chemical adjuvants, we have hydrogen peroxide and phenol alcohol. Hydrogen peroxide, this is a recently published paper from a very large series from Dr. J. Wonder and group in Canada, who have reported that the local recurrence rate is reduced by the use of hydrogen peroxide, though it is not statistically significant difference, but they have seen a remarkable reduction in the absolute rates of local recurrence in the patients where they have used hydrogen peroxide. Coming to phenol and alcohol, it's a most debated or most controversial of the lot, where you will find papers which says that phenol is absolutely useless. There is no added advantage of using the phenol. In fact, it can be really harmful to the patient. Where if you have people who are kind of fans of phenol and alcohol, who says that use of phenol will certainly reduce the local recurrence significantly. This is the patient where they have compared uh, 63 patients of grade 2 and grade 3 GCTs who were treated with BOR, phenol, alcohol, and cementing, and the local recurrence rate was only 6% at 9 years follow-up, which is quite remarkable. So when you have to use phenol, what is the percentage of or the power of the phenol that you have to use? You only need 6% of the phenol. You don't need 70% or 80% of the phenol. All you need is 6%, which should be applied for more than 3 minutes, taken on a swab. I personally feel that in a case like this, where the articular cartilage is deformable, soft ping pong ball like, this is where you cannot use BOR optimally. You can neither use electrocautery because you're worried about thermal damage. These are the cases where phenol and alcohol will be certainly of great use. So what precautions should be taken while using the phenol? Well, phenol is really toxic. When you're using the phenol, you have to constantly keep sucking it so that there is no seepage of the phenol in the surrounding soft tissue, especially when there is posterior cortex deficiency and all. You don't want your phenol to go around the vessels, and you have to wash it out with absolute alcohol because body has no mechanism to excrete phenol. There are papers which says that if you biopsy a neighboring lymph node, even after a year of use of phenol, you will find traces of phenol in those lymph nodes. So if you have to properly wash it out from the body, because phenol itself is a known carcinogenic. So this is a complete video of a giant cell tumor curettage. After securing the surroundings, you make a large window. With the primary gross tumor, usually I use spoons, so that a large chunks can be taken out at once. Then you use bigger curettes to do the primary curettage. You keep removing the gross tumor, and then you do this first wash with the hydrogen peroxide. This is where this is how it looks after the primary curettage. Then you start using your high-speed burr, and as you can see, it is so beautifully clearing up all the cortices. You very carefully use this burr to each and every corners. Don't miss out on any areas. This is how it looks after the hydrogen, after the burring. Then this is how an electrocauterization is being done. Carefully each and every corner of the cavity is.
Mandip, we have to quickly wrap up.
Yeah. And then you use phenol and alcohol, and then so again, if you look at some literature which says that if you have used all three adjuvants, you could achieve better disease clearance. Just a little about post denosumab cavity curettage, because we have been using denosumab more frequently, and once you use the denosumab in cases like this, the cortices would certainly become much better. The care you have to take is that when your extent of the curettage should make you go back to the pre-denosumab levels. Unless you do that, you will leave behind disease, and then you can do the reconstruction. Cement does reduce recurrence rate, and we have multiple literature which says that the cement is extremely important, extremely useful in reducing the recurrence rates. I will skip this because my friend Dr. Akshay Tiwari is going to talk about phenol and bone graft. So what is better? How do you reconstruct the cavity with these kind of options? And that is where I will ask Dr. Akshay to take over. Thank you very much.
Thank you so much, Mandip. Thank you so much for a very lucid and elaborate talk on role of curettage in giant cell tumor. And there are a lot of queries related to this, and I'll quickly ask you a few questions before we go ahead to the next. Do you think that curettage is a good option for GCT, or all GCT should be resected? Because if we don't resect them, they come back and they become malignant.
No, I think, as I said, in fact, majority, almost 80 to 85, maybe more than that, patients would be extremely suitable candidates for curettage. These are benign tumors. These are young individuals. These are periarticular tumors. And that is why we should do everything possible to save the joint. And that is where the method of choice for most patients would be curettage. Unless, the cases which I pointed out where curettage is just not possible, where the curettage would, that you're leaving behind gross disease and patient will have 100% have recurrence. That is when you should not do curettage. But in my practice and even in your practice, 90% or more cases would undergo curettage. Now, malignant
Absolutely.
transformation from a GCT is known, but that usually happens after multiple recurrences. And that is, in fact, in our practice, we very rarely see that kind of secondary malignant transformation of giant cell tumors. So that is really not my concern. Even if the patient has a recurrence, you can, most of the times you would be able to do a repeat curettage and save the joint. That is what we usually do.
Okay. My second question to you is curettage is like any other simple procedure which anybody can do, or it has to be learned properly and only then practiced?
Absolutely. I mean, there is no debate here. Any surgery, for that matter, even a simple nailing, needs to be properly learned. These are much more complex and complicated cases and surgeries. And that is where, even you and me, after so much of experience of probably almost 2 decades, sometimes we also feel that we did not do a proper job. It is possible. So, but unless you have proper expertise, experience about treating these cases, you should not indulge into this. Because even a busy orthopedic surgeon would see probably 2 giant cell tumors in a year. And that is certainly not a good experience. So I think you should go to an expert, and they should be doing this treatment.
Just last question quickly. Is BUR mandatory? I know you have addressed it, but I want to emphasize it again. Is high-speed BUR mandatory for doing an extended curettage?
High-speed BUR is absolutely mandatory. And it should be a proper BUR, not a BUR point loaded over a simple drill. You should have a high-speed BUR, high speed meaning by more than 35,000 RPM. So high-speed, high-torque burring is needed.
Thank you so much. Thank you so much.
Thank you.
Without any ado, let me invite another dear friend and eminent orthopedic oncosurgeon from Delhi, Dr. Akshay Tiwari, who's Director of Orthopedic Oncology Services at Max Group of Hospitals, and he has been the torchbearer for orthopedic oncology in Delhi and NCR. And Dr. Tiwari is going to speak to us upon that when Mandip has done a good curettage, then how he reconstructs the cavity in the best possible way and what works best. Dr. Tiwari, all yours. We are not able. Yeah, audible.
Audible, and is my screen visible?
Yes.
Thank you, Ashish, for that introduction. And I have to thank the Oncology Committee of Indian Orthopedic Association. I'm delighted to be here with all of you once again. So as Ashish just said, my job is to reconstruct the cavity that has just been left by Mandip after a thorough curettage. And that becomes an equally important part of the whole surgery or the whole management of giant cell tumors. And as Mandip said, curettage sometimes may be contraindicated just for the fact that you may not be actually able to do a good reconstruction after your curettage. And that is where all the wisdom of choosing between curettage and resection lies. So the question or the topic of my talk that has been given to me is what works better for reconstruction, bone graft, cement, or sandwich. And This topic is in a way self-explanatory about the menu that lies before us to choose from when we go about reconstructing a cavity like this after a good curettage has been done. You could either fill it with cement. It's commercially available, not very costly, no added morbidity to the patient, and a delight to the surgeon because it's quick and easy. You might go for bone grafts, which could be morselized bone grafts, which could be strut bone grafts, either placed obliquely or as a T construct, or it could be an allograft or an autograft for that matter. Or you could marry the two techniques and you go with what we call as a sandwich technique, where we can see a bone graft placed just below the joint cartilage, separated by a layer of gel foam, and then cement filling the rest of the cavity. But before I proceed, I must say that the Greek goddess Panacea could treat all diseases, but that is not the case in real world. And so is the case with giant cell tumors when it comes to reconstruction. So I'll want to tweak the question a little as to what works better for whom, because a bone graft may be suitable in a certain situation and cement may be suitable in a different situation, depending on patient conditions, surgeon factors, and also the center where you are working at. So with this background, I go ahead and I'll definitely quote this rather simple flowchart that a review paper by Dr. Puri and Dr. Agrawal back in 2007 said. They put the age limit for cementation versus bone graft at 50 years. And they also put 5 millimeters of subchondral bone as to whether we should choose or should not choose to have a sandwich. And we will see how it evolves as we go along my talk. But before I proceed, I must mention here that we must consider the fact that sometimes we might just get away without doing any filling. And that is where papers like these who have proven that curettage of benign bone tumors without grafts can actually give sufficient bone strength if there is 2/3 or more of cortex still available and you have still good subchondral bone to support. Going ahead, and I think a lot of literature is there. For some questions, the jury is still out. For some questions, we kind of know the answer, whether to choose between cement and bone graft or sandwich for that matter. Does filling material affect local recurrence? And that is where the consideration of Dr. Mandip on doing a good curettage extends. You'll love to have a filler which will keep curing disease as you fill the cavity. And that is where the question, a very important question comes. This paper from the Birmingham group talks about the cemented group having a much lower local recurrence as compared to just bone grafts without cementation. Another paper in 2008 in JBJS American talks about the use of cement as an adjuvant, significantly reducing the recurrence rate following curettage. Again, the Scandinavian sarcoma study group showing 294 patients where cement significantly reduced local recurrence as compared to bone graft. And not just that, this Chinese paper also talks about the recurrence-free survival being much better with the cementation group. But then there'll be a few studies which will question this effect of cement on local recurrence. For example, this Canadian sarcoma study group study, which said there's probably no difference in terms of local recurrence, and it all depends on a good curettage that you have done. Does filling material also affect the health of the cartilage? In other words, does it lead to an earlier osteoarthritis than otherwise? The considerations here are, it's not just the filling material, but also the disease which has caused the osteoarthritis to happen. For example, the area of subchondral bone involved, whether it's 90%, 80% of subchondral bone that was involved. How far is the tumor from the cartilage, whether it's 3 millimeters, 5 millimeters, or 10 millimeters? Number of recurrences and repeat curetages also accelerate osteoarthritis. And then, of course, there's a concern of the cement, the very thermal necrosis that extends your curettage and leads to better local control might actually be damaging your cartilage, which is a big concern in a young patient who is going to require an earlier joint replacement should he or she develop an osteoarthritis. People have also tried to look whether it's the synovial fluid or the subchondral bone that is the dominant source of nutrition for the cartilage. Again, the same paper from the Birmingham group said that the osteoarthritis is probably accelerated in patients who undergo cementation as compared to bone grafting, and they are more likely to require joint replacement. Other papers, this Chinese paper said if there is no subchondral bone graft, it's an independent prognostic marker for secondary osteoarthritis. Another Chinese paper which says the less than 10 mm of subchondral bone leads to higher chances of secondary osteoarthritis, which will be more in the cementation group as compared to the bone graft group. And again, this paper from International Orthopedics says that the chances of acceleration of osteoarthritis is more with cement. But now, as time passes, there's an equally larger group of studies which actually say that probably cement is not accelerating osteoarthritis, and it's actually the disease, the recurrence, the involvement of subchondral bone is what is responsible for osteoarthritis. This paper in 2017 clearly says that curettage cement packing did not actually have an effect on development of osteoarthritis. Again, this paper from Sweden says that the long-term presence of cement close to joint does not lead to degenerative osteoarthritis. Another paper which does not find cement as the cause of osteoarthritis, and the Rizzoli group also echoes the findings of the previous three papers. People have also tried to look at whether the nutrition of the cartilage comes from synovial fluid or from subchondral bone. And this study actually found that it's the synovial fluid which actually gives most of the nutrition to the cartilage and not the subchondral bone. So whether cement leads to an early osteoarthritis, the general opinion is probably yes, but there is an increasingly growing data that says that probably not so much. What about function? Is it any different between bone graft and bone cement? The answer is no, and the literature is absolutely agreeing on at least this fact. This paper talks about the MSTS and SF36, which was similar between cementation and bone grafting groups, and so does this paper in International Orthopedics. A host of other studies will also agree that the function between bone graft and cement groups is just the same in the long term. What about a pathological fracture? Generally, one would think that a pathological fracture will usually do better with a bone graft because it will give an added scaffold and also the material to grow on and for the fracture to heal. For example, this patient had a pathological fracture. We can see the varus and the collapse medially there. We used fibular strut grafts and also some bone graft substitute, and gradually the fracture healed and the patient is doing well about 6 years after this surgery. Another patient where the cavity was very large and we did not think we could use just bone graft, and we actually used cement in the form of a sandwich where we placed bone grafts next to the pathological fracture and filled the rest of the cavity with the cement. The cement will actually hold my implant well and also give a strut to the bone grafts and the fracture fragments to stay in place. This patient has done well 8 years after surgery, although we can see some valgus collapse there, but he's still doing fine. Again, the literature also says that cementation is not actually absolutely contraindicated in patients having a pathological fracture. What about age? Does the choice depend also on age? Logic will say that younger patients should usually be treated with bone grafts rather than cement, because in young patients, you are concerned about remodeling that is going to happen, the growth that is going to happen. And then probably the grafts will be the natural choice for a young patient, especially the patients who are skeletally immature. But can you use cement in skeletally immature patients as well? This patient came to us back in 2015 with a recurrent giant cell tumor. Again, GCT is very rare in this age group. And we ended up using cement and bone graft substitute longitudinally placed next to each other, and she's doing fine more than 8 years after surgery. Literature also talks about use of cement in skeletally immature patients, and this paper actually found no difference in the long-term arthrosis or growth-related deformities in skeletally immature patients who were treated with cementation. What about post-operative complications? Because this is going to be another area which will make the surgeon choose between bone graft and cement. Literature is divided. Remember, bone graft, autologous bone graft harvest may be a small and simple procedure to most of us, but sometimes it can also have complications. Looking at literature, this paper said that maybe cementation has a higher post-operative complication rate as compared to bone grafting. But then this paper absolutely negates and says the complication rate was actually lower in cementation group than in the bone grafting group. Does the site of affection also affect the choice of your filling material? The answer is yes. Most horizontal bones will usually do better with bone graft than cement, because cement is a poor material if loaded in shear as compared to when it's loaded longitudinally along the line. Which is why this paper by Dr. Yogesh Panchwag and others talks about benign bone tumors of femoral neck, and where they used bone graft in all the patients. And it makes sense because cementation is more likely to fail in this location. Similarly, the small bones of hands and feet will more likely be treated with bone graft than with cement, because there'll be small cavities. Quite a few of them will be horizontal bones and will do better with bone grafts than with cement. For example, the GCT of the talus was treated with the malleolar osteotomy and then filled with the bone graft and did well. But can we also use cement in hand and foot bones? The answer is yes. This patient had a recurrent GCT of the metatarsal and she did not want a resection. We ended up doing a curettage and also filling it up with cement along with an intramedullary K-wire for support. And she has been doing well almost 10 years after surgery. A distal tibia, again treated with extended curettage and cementation, doing well 2.5 years follow-up. And we actually collected our data of about 18 patients of foot and ankle GCTs. And this study found that cementation does actually as well as bone grafts for giant cell tumors of foot and ankle bones. What about the situation where there's an extensive cortical loss? And these patients will actually be an extended indication of curettage. And as Mandip pointed out, on the one hand, you're concerned about whether you'll be left with enough cortical bone to reconstruct. And on the other hand, you're concerned that these are young patients and resection should only be kept as a last resort. So if there is extensive cortical loss, generally you would want to fill it up with bone. This paper talks about morselized allograft, and again using a cortical allograft to close the window. And it makes all the sense. But the thing is that whether the morselized allograft can actually hold the construct for that long. And a similar situation where we filled it up with cement, there was absolutely no cortex. And look at what happened in the post-operative period, where the cement actually extruded because there was no cortical bone. And also the cement was not supported with any other intramedullary material. So we came up with the thought that maybe the sandwich technique that we use horizontally to salvage the joint or to reconstruct the subchondral bone would actually be used in a longitudinal fashion, and then reconstruct part of the cortex and maybe extend your indications for curettage. We studied 12 of these patients, and as we can see here in extensive cortical loss, instead of the horizontal sandwich, use a longitudinal sandwich. And this case demonstrates the same, where we curated and placed bone graft on one side and also used fixation. And we can see here the bone graft has remodeled well, and it's actually now remodeling in that young patient. The patient remains free of disease. Another patient who had a pathological fracture, a ping pong bone on all sides, we treated with the longitudinal sandwich. Part of the cortex was reconstructed with the bone graft and the remaining was filled with cement. And this is a good compromise between two, where you don't have access to a bone bank. You have limited amount of autografts. You could actually use both cement and an allograft in these patients. And this patient recurred, again, a bone graft substitute was placed. And now this patient is doing well, more than 4 years follow-up, good range of motion. We can see the varus collapse, but the joint is still salvaged. There are a host of other factors which we should not and cannot forget, because these factors will not be addressed in literature. Bone remodeling is something that remains at the back of our mind, and we cannot forget that cement is actually an artificial material. What will happen in the long run in a young patient? A future joint replacement is going to be easier if required in a patient who underwent a bone graft rather than cementing. A salvage or recurettage may also be easier for a patient who underwent bone graft. But what about a soft and deformable cartilage? If you think there's absolutely no subchondral bone and just cartilage, you might want to give it a solid strut, which only cement can give, because autografts, either if they are cortical, will not match the shape of the cartilage. And if they are morselized, they will not be strong enough to hold the cartilage there. And the chances of a fracture of such a cartilage are higher if a sandwich or a pure bone graft is used. Availability is one more thing that needs to be at the back of our minds, because bone banks are not available to at each center. The ease of picking up a recurrence is another advantage that cement offers to us, because a good radiolucent line forms around the cement, and it's very easy to pick up a lytic area that's developed by following serial X-rays. Rehabilitation time, again, it's something that we need to discuss with our patient when we choose our filler, because a patient who asks you to make her walk up in say 4 weeks or 6 weeks, going back to the pre-surgical levels, it's only cement that can give you such a short rehabilitation time. This systematic review tried to address all these questions. And
Akshay, last 1 minute, please.
Yeah, so they tried to address all the questions between bone graft and cement, and they could actually see that the local recurrence is much better with cement, and most of the other factors are actually comparable between the two. Just some cases in point: a distal femur treated with cementation and fixation, a distal femur treated with bone graft substitute, a rare metaphyseal GCT treated with bone graft and fixation, and a proximal tibia treated with the sandwich technique. Again, a proximal tibia treated just with cement and plate, a metacarpal GCT treated with a strut corticocancellous bone graft, a GCT distal radius because of a very deformable cortical bone all around was treated with cementation and also temporary external fixator, a distal radius GCT treated again with curettage and bone graft and cement, a proximal humerus treated with cementation and plating. So when it comes to choosing between the two, if it comes to immediate function, cement will score above bone graft. Large cavities, cement is the easier material to use. Donor side morbidity, cement scores above bone graft. Higher chances of osteoarthritis, bone grafts will score above cement. Revision surgery will be easier if you do a bone graft. And the local recurrence will be better if you use cement rather than a bone graft. And long-term functions are going to be the same between the two. So just a simple algorithm: if it's a young patient, choose bone graft over cement. Location, femoral neck, small bones, maybe you'll choose bone graft over cement. Subchondral bone, if it's less than 5 mm or maybe less than 3 mm, you'll end up using sandwich or a bone graft. And in cases of large cavities, if you don't have allografts or bone bank available, you'll probably use a cement or a sandwich. And other considerations we've already discussed. And this is how you ultimately come to the choice of your reconstruction or the filler material. And patient's preference is something that is always at the back of our minds when we choose between cement and bone graft. It's always better to solve one problem 5 different ways than to solve 5 problems one way. And we've got these 3 ways of filling, and we need to choose judiciously and choose what we and the patient are comfortable with. Thank you, Ashish, for the extended time, and I'm happy to take it.
Thank you, Akshay. Thank you so much. I know it's always been a situation of dilemma, and it's always been a debate multiple times whenever we discuss how do we reconstruct and what works best. I think you've very beautifully shown the algorithm and shown the examples as well, where how we can reconstruct these cavities also. May I request if you can stop sharing so that we can invite the next speaker as well. Now moving on further, it's my pleasure to invite current president of IMSOS, Dr. RR Saggar, very eminent orthopedic onco surgeon from Jalandhar. Dr. Saggar has vast experience in managing giant cell tumors, and he's going to show you his technique of doing the curettage by a video demonstration, and we can have some questions after that. Dr. Saggar, please. Dr. Saggar, you are not audible.
Am I audible?
Yes, now you are audible. All yours.
Yeah. Thank you, Dr. Ashish Gulia, for the kind words, and thank you, IOA, for a beautiful platform to talk about the GCT. And now, since my topic given is the video demonstration, in these next 8-9 minutes, I'm going to talk about the video, though Dr. Mandip has touched the salient features. And this is like, for example, eccentric lytic lesion, classically involving the medial side of the femur. And you can see the large soft tissue mass, which is extraosseous mass. and there's a cortical break on the medial side. And hence that is how we, during the pre-op planning, we decide which approach to be used. And this is where the cortex is thinned out or cortex is broken, or there's a soft tissue mass there, and we decide the approach. And this is a basic set of instruments: curettes, spoons, rongers, nibblers. All these things are just required. We will use all of them one by one, and we'll get into the details very soon. Now, to begin with, now this is the tumor. We mark what is the average size of the tumor, and the length of the incision has to be longer than the size of the cavity. That's the first thing. The surgical approach I've already mentioned. On the side where there's an extraosseous mass or where there's a cortical breach, that is the side we approach. And then gradually we have a long incision, raise these flaps, reaching up to the subcutaneous tissue. And as we raise these flaps, in interest of time, then we start these hydrogen peroxide soaked gauze pieces on either side, and these self-retaining retractors being put in so that we prevent the tumor spillage. Now, once we do it, then we gradually mark this soft tissue extent of the tumor with the help of a cautery. And this is how we make the window. And obviously, the entire biopsy tract has to be excised in this soft tissue mass. Now, once we, Dr. Gulia, I think you're audible to me. So once we remove this, then we use a knife to deepen this excision. And after the cautery marking, we take this knife, we excise this entire extraosseous mass, and actually maybe partly entering into the cavity. And this way we start removing the tumor. Then as we keep on deepening it, and in this entire tissue has to be removed, and then the first instrument which I use is a large spoon. It helps me to take this soft tissue mass out before I get onto the smaller size curettes. When we're lifting it out, it's very important that all these tissues, all these instruments are going into a separate draping sheet where we are using, so that we can sanitize this area later on. We use these curettes, we use this bone nibblers, and this is exactly how we keep on putting our instruments on this kidney tray, or which is lying on a separate sheet, so that they don't go back to the trolley. And as we keep on cleaning with the curette, we do the gross curettage, that is a gross soft tissue through this window, which is being removed. And this is what we all aware. Then the overhanging soft tissues, now we can identify, which we start removing with the help of a cautery, and then further curettage is being continued. And this way we keep on enlarging the cavity converting this window into a door, which Dr. Mandip did mention about. So as this more tissue is removed, this is how the overhanging soft tissues are being removed. This is very important because whenever this tumor is coming back, it is coming on the inner side of the margins, which are facing the surgeon. And that is why these overhanging soft tissues margins, they have to be excised. And this way, how the cavity is gradually, this window is gradually enlarged. And finally, as we have now the bony margins coming up, we keep on curating the tissue. And then as we keep on removing it, and we also use a 50 cc syringe with a normal saline for a better visualization of the cavity. And it is very important to use a headlight at this moment. And then we start enlarging again. Now with the bony margins, we can use upcutting rongers. And this is again how this door is being made. And that way how the entire cavity is being looked into it. And so that there's no overhanged margins all around, and any loose piece which is lying up and down is being removed. And then gradually, as we keep on cleaning it, now you can see all those red and black areas, which Dr. Mandip did mention that those are all tumor areas. And we keep on cleaning with the normal saline, the suction, no spillage around. So we keep on cleaning it, then put in the dental mirror, see the undersurface again. If we see a tumor there, and this helps us with a good headlight on our head, and then we can remove that tumor tissue and we can identify it. and that is how we continue with the mechanical curettage. This mechanical curettage is followed. We extend this curettage with the help of a high-speed burr, which is, in this particular case, I'm using a diamond cutting coarse burr about 80,000 RPM. And on the cortical side, we go about 2 to 4 mm. On the canceller side, we go almost up till 1 centimeter. And this is to be done looking at one by one on each wall of the cavity. For example, if I'm starting from the medial side, we do the lateral wall, we do the roof, proximal, lateral, one by one, and so that we identify which areas to be worked on. Simultaneously, the saline wash is being done, the suction is being done, and as we can see, this white thing, nice underlying bone getting cleared up because all the crevices is getting cleaned up and helps me in identifying which are the areas left with. This is how the extended curettage cavity looks like, and we continue with this curettage. So this has to go on stepwise, and so that we don't miss an area which is not curated out. And this is now I'm going towards the articular end, and as we keep on identifying, about 2 to 4 mm of the bone is being cleared up with this high-speed burr. So this is how Dr. Mandip did mention, because he showed a lot of videos, and that's how the extended curettage makes a cavity look pretty nice in front of us. And obviously all those incomplete septas to be removed, and then pulse lavage is very, very important, which washes the entire cavity, and the extra suction is being used so that there's no spillage around. Once this pulse lavage is done, that the entire cavity is washed, it is very nicely visible cavity is seen, which we can absolutely, it becomes pretty clean cavity, and then which becomes easy to reconstruct now, and we can plan how this cavity, how strong this cavity, we look at all the walls of the cavity, we can even assess what, and if there's any area left in, which is like any suspicious area, we can again do the curettage in that area after the pulse lavage and keep on washing it. And then after this, you can see the separate sheet, all these instruments, all this tumor, all this is being picked up. The draping is changed, the gloves are changed after this, and this is how we sanitize. And then we put in this hydrogen peroxide soaked gauze pieces. This is now a kind of a chemical augmentation of the extended curettage, which does help. In fact, it is also cleans up the cavity much better way, good hemostasis. And now we also assess the strength of the cavity. We assess the stability of the cavity, that what kind of reconstruction is required. And then we can also further augment this curettage with the easily available cautery to the tune of 80 or 100 strength, and it really burns it again stepwise, looking at all the walls, all the margins, all the areas except the soft tissue areas. There also we have to be very careful. We remove all those periosteal sleeves, and that is a place where we have to be cautious. And then gradually we decide the kind of reconstruction we need to do, cement or bone graft or cementing with the implant. And in this particular case, it was possible to put in a plate and then put in the cement again. And this is just to, because it's just 8 minutes video, so I'm not going to really go into the details of how to reconstruct. And then finally, this is how it was all done. And then we check on everything on the C-arm, that the implant and the cement are in right place. So with this, so the last few slides, we look at the cautery, suction, good elimination, bone nibbler, upcutting rongers, sharp curettes, spoons, high-speed burrs, dental mirrors, 50cc syringe, pulse lavage system, they're all must in the armamentarium. And last of all, these steps are very important: which side, length of the incision, this hydrogen peroxide soaked gauze pieces, extraosseous mask, window converting into door, mechanical and extended curettage, and augmentation with the chemical and thermal curettage. Thank you for your kind attention.
Thank you so much, Dr. Saggar. Can you please stop sharing and then?
Yes, sir.
Okay. So, Dr. Saggar, do you always use intraoperative adjuvants like alcohol and phenol?
in the initial years, yes, I was using maybe about 10 years back. Now I'm actually not using phenol at all. I'm very happy with the hydrogen peroxide and thermal, which are easily available to me. And this is reason for not using phenol. I find this to be handled very carefully, and I don't see an extra advantage of using phenol over the current video which I showed.
Okay. Srinath, what is your take on it? And any experience with using liquid nitrogen?
No experience with liquid nitrogen or phenol, sir. I've been using only micromotor burr, high-speed burr, and hydrogen peroxide and a pulse lavage, which has given me good results so far.
Okay. Akshay? Please unmute yourself.
Ashish, I have still been using till now using phenol and absolute alcohol because they have worked for me so far, so there's no reason to do away with them.
Okay. But you are sure that alcohol and phenol is working?
Well, I'm not sure they're not working. So that's how I'll put it.
So maybe we need to sort of club the cases and see. Great. Suman, how about you?
So same here. I'm not using any except hydrogen peroxide. I'm not using phenol or liquid nitrogen. But one thing, as sir mentioned, you have to be very careful if you're using liquid nitrogen, because I had seen a case where the surgeon had no idea about the property of liquid nitrogen. It was poured into the cavity, and whole the bone and the tissue was completely necrosed, and patient has to undergo amputation. So the what I wanted to say is, yes, there's no exact data whether these adjuvants work. If you really want to use, you should know their property and use it in a better way. Otherwise, simple hydrogen peroxide works.
Thank you so much. So now it's my job to speak to you, and I'll just share my screen, make sure that it is visible and audible. Am I audible and visible to all of you?
Yeah.
Okay. Thank you so much. So thank you so much, and greetings from Orthopedic Oncology Services at Tata Memorial Center. Now we are growing from just the TMH branch to various other branch. We have started services in Varanasi, in Vizag, and now recently in Punjab as well. So, okay, it's not going ahead. Yeah. My topic, which I have to speak to you, is about denosumab, the role of denosumab in giant cell tumor, why and how I use it. Just the basics, that it's a fully monoclonal antibody against rank ligand, which inhibits bone destructions by preventing the rank ligand mediated formation, activation, and osteoclast-like giant cells. This is a schematic diagram which shows that denosumab binds at multiple levels. At first, it inhibits the tumor growth factor beta, interleukin growth factors, and fibroblastic growth factors, along with VEGF, anti pathway, and it also acts on the osteoclastic giant cells, where it inhibits their activation and it prevents resorption, and hence it helps in bone formation. So this acts at 3 levels, and that's why it's more potent than zoledronic acid. The Amgen trial, which was published in 2008, which got denosumab to all of us, was specifically designed for unresectable giant cell tumors of the spine and sacrum. In Amgen trial, they gave a dose of 120 milligrams subcutaneous with a loading dose of 4 injections in the first month at these days as mentioned here, and thereafter they have given monthly dosages, and this was advocated to be given lifelong because denosumab is only an adjunct and it is not the definitive treatment. But we all know that the cost is extremely high. The original molecule is about 24,000 rupees in India. We have the biosimilars available from Reliance, from Intas, and now from Alchem as well, where the cost is about 50% of the original molecule. We recently also studied the use of biosimilars only for the adjuvant as surgery, and they seems to be equally effective. But we can't give them lifelong, and our patients who have to pay out of pocket, it's extremely difficult to afford. FDA has approved denosumab for various diseases, and in addition to giant cell tumors, it is approved for osteoporosis. It is approved for metastatic bone disease. It is also approved for skeletal related events in solid tumor metastasis. So, in nutshell, it's being approved slowly for a higher number of patients, but at present, the surgical use is you can consider as an off-label use. So, how I use denosumab in my practice is first is to facilitate surgery. And when I talk about surgery, it can help me in three different modes. Number one, it can help me to facilitate the curettage. So these are the patients where I know that I'm going to do the curettage, but I'm not sure how effective it will be towards the periphery where I have to do this curettage pretty effectively. So it helps me to form a shell. Second is that it will help me to convert few of the resections into curetages. So these are the borderline patients where I'm not sure whether I will be able to curate or resect, but I want to give a trial of denosumab and maybe I will be able to convert few of their sections into curettage. And third one are the cases where I know I will be doing a resection, but I'm very scared of the spillage because of the huge tumors. And then at this place, I give them denosumab to form a nice shell, solidify it, and remove it nicely. Third is, as I told about the Amgen trial, that this have been advocated for unresectable giant cell tumors of the spine and the sacrum for the metastatic disease to decrease the skeletal related events. And we've also found it very helpful in relieving the pain and the neurology in the spine tumors. So let's see some examples. And the first one is to facilitate the curettage. This is the giant cell tumor of the proximal tibia. You can see the disease going right up to the subchondral bone. This is the MR showing a soft tissue mass, which is close to the proximal tibiofibular joint. You are not sure whether you will be able to do an adequate curettage or not. These are the cross sections. And then we give denosumab, and post 3 or 4 cycles, you see nice consolidation happening. And this is the curettage where I could save the joint. And this patient was operated about 4 years back and now doing pretty good. And this is a 24-month follow-up of that patient. Moving ahead to see how we can convert few resections into the curettage. Now, giant cell tumor of the distal radius are pretty notorious, and our threshold for doing resection is pretty low. Similarly, in this case of a young boy from Kashmir, he was to be an aspirant engineer, and he came to me long back where he had this giant cell tumor. We gave him 6 doses of denosumab. You can see nice consolidation happening. I could curate him, save his wrist so that he's quite functional as a computer engineer, and then prevent his function. 12 months later, he got a recurrence as well. But the best part was I could identify the recurrence pretty easily because I had put the cement, and then I could recurate it and still restore the movement or save his joint. And now he's completely recurrence free, almost 5 years down the line, and he's doing pretty good. Third one is when I'm resecting and how to facilitate it. This is the massive giant cell tumor of the pelvis arising from the ischium, which involves the acetabulum as well. And we know that in no case you can do a curettage here. We are extremely worried about the spillage. As in the MRI picture, it's about 20 centimeters tumor, which is going inside the pelvis and in the groin and the upper thigh as well. These are the cross-sectional imaging showing the involvement of the posterior acetabulum also, and in intrapelvic and extrapelvic mass. After 6 doses of denosumab, you could see a nice consolidation happening all around, and he was operated with resection and partial curettage of the posterior column, and we could save his hip joint. And that's the beauty of using denosumab in selected patients. Now, surgically unresectable patients, and this is where the Amgen trial was done, and this is an off-label use in a 6-year-old child where giant cell tumor of D11 spine. He came us with deficit, and this was his MRI, SAG, and cross-sectional images where you could see this is intraspinal and extraspinal disease. We started with denosumab, you can see, and we also combined denosumab with 6 doses of angioembolization. And then you can see very nice consolidation and stabilization of spine happening. And this is a 2-year follow-up of this patient, and he's doing pretty good. This is the follow-up MRI, which says the disease is stable and the spinal cord is pretty free. In metastatic disease, both to prevent these skeletal-related events, and also we have used in giant cell tumor where they have metastasized to the pulmonary parenchyma as well. We all know that giant cell tumor metastasizes in very large number of nodules in the lungs, and most of the times it is not possible to resect all of them, though they grow very slowly, but we know that they can be life-threatening, and this is also where we have used denosumab in this patient who had multiple pulmonary metastasis from giant cell tumor. The use is not pretty easy. It is surrounded by controversies, and for like bisphosphonates, we are very scared of its prolonged use because it leads to atypical stress fractures, critical hypercalcemia, and osteonecrosis of the jaw. As I mentioned earlier, the pediatric use is not recommended below 12 years because it can impair the bone growth in children and can inhibit eruption of the dentate and dentition. Denosumab withdrawal is also known for the higher tumor recurrence, and this is where we need to be very careful if we are using as a definitive therapy. So what's the current status and how do you use it? FDA has approved it for unresectable lesions. Now there are many off-label indications, mainly in the surgical treatment, and as I have shown you a lot of examples for the same. People talk about increased local recurrence with the use of denosumab, but I sincerely don't feel so. And our data from Tata Memorial have clearly shown that if you use them for select patients, you'll be able to save many joints, and the local recurrence rates will be similar, which would have been otherwise in same Campanacci grade 3 tumors. The use in pediatric patients is still controversial, but we have been using as an off-label where we do not have any other option left. So how we move ahead in future directions from here? There have been a lot of trials happening, and when I was reviewing the denosumab, it is one of the highest studied molecule in orthopedic oncology till date. Now there are a lot of trials which are looking at whether the intensity of the dosages should be reduced, whether duration of the treatment should be stopped, whether long-term side effects are really a threat or not, and whether malignant transformation is actually happening or not. So now currently we have started using less number of dosages pre-operatively. Earlier we were giving 4 and then monthly. Now we just give 2 or 3 doses and then wait for some ossification happen and curate them. We've also we have also started increasing the duration between the 2 doses so that the just optimum or just required ossification happens, and we curate or resect these patients, and this helps us to formulate a cost-effective treatment as well. Thank you so much for listening to me, and I'll be happy to take any questions if they're on the chat box or by the panelists. Akshay, Dr. Saggar, Suman, any questions for me? I'll be happy to take it.
So Ashish, a nice talk. My question to you is that for definitive treatment of unresectable giant cell tumors, what is your end point of using denosumab? And is it marked by the duration that you have given denosumab for, or any other modality that you have added to denosumab for that patient?
So it depends upon what I'm looking at. If it is only for curettage, initially, as I told you, we used to give large number of dosages and look at the ossification. And we were looking at a very intense ossification to begin with. And this is where the recurrence rate increases, the local recurrence rate increases because we were not able to curate very thick ossification. Now we have modified it, and now we understand that you just need to have some sort of ossification or actually a partial ossification for doing a better curettage. If I'm doing a resection, I might give a few dosages extra because I want it to be really solid so that I can take it out pretty easily. For unresectable tumors, we are not using as a lifelong modality, to be very honest, because none of our patients will be able to afford it. So we are always combining it with angioembolization. We have assessed our data and found that the response rate is about 50% in these patients, and 50% of patients have reoccurred where we have re-challenged them in some of them with again denosumab and angioembolization, or in others we might have treated with surgery or radiotherapy. That's how been the protocol.
Yeah, and the next question is in resection following denosumab, do you find the resection planes actually easier because the handling is much better, or do you have you also find, like I have found, a lot of fibrosis surrounding the tumor, which makes your resection a little tricky?
Yeah, I completely agree with you, Akshay. So when we give denosumab, there's a fibrosis happening at the periphery. But when we know that it's a benign tumor, it's very easy for me to go very, very close to the shell and sort of cut through that fibrosis. So yes, fibrosis is there, but actually it really helps, and you can just go all along that fibrosis and cut it open. It's actually pretty safe, and I'm quite comfortable with it.
And sorry if I'm not eating into the others' time. One last thing, what is the longest duration that you have administered a patient with denosumab?
16 months.
Okay, so I have had patients who have been on denosumab for years. So as you said, we start because both of these patients were multicentric giant cell tumors. There's no way you can offer angioembolization or radiation or surgery for all those tumors involving spine, pelvis, cervical spine, and whatnot. So I've had patients who I kept increasing the dose duration. They are now on 6 monthly or yearly denosumab and still doing well. It's been 8 years for one of them and 6 years for the other. I'm not sure where we are heading. We keep challenging them for increasing durations of non-denosumab therapy. But, yeah.
So I have a couple of suggestions on this. Number one, recently, last month or maybe this month only, we have a paper which talks about the local recurrences post stoppage in denosumab, and the same abstract was presented in AMSOS this year. And they talk about that more than 50% of the patients they do not reoccur after an average of 18 months of denosumab. So maybe and obviously in Europe and in UK, they have also started practicing something called as the drug-free period. So you can definitely stop denosumab easily for a year or year and a half and try to see how they behave. What I have started doing in Tata Memorial from past 2 years is that when we were treating these patients with angioembolization and denosumab, and we found that 50% are recurring, and looking at the basic biology, that denosumab is a static drug, while zoledronic acid can be a cidal drug. I have added 6 doses of zoledronic acid post completion of angioembolization and denosumab. Though the data is raw, but I'm not sure. We are still evaluating it. But these are the 2 strategies which you can use. That you can give them a drug-free period. Definitely, a patient who's 8 years, I think you must give them a drug-free period for maybe 1.5 to 2 years. And other patients who have shorter duration, maybe you can switch them to zoledronic acid and sort of follow them.
Yeah, so the one in 8 years, we gave a drug-free period. 18 months later, she recurred. So we started. But I agree with the strategy. Yeah.
Thank you so much.
My question to Ashish, sir, the last question would be,
yes, Suman.
There is a malignant transformation associated with giant cell, even though the percentage is small. I really want to know, I think there was a case in TMH. I want to know what happened to the patient.
Yeah. So globally, when I had reviewed it, we have about 11 or 12 cases of giant cell tumor, which have been sort of diagnosed with malignant transformation post use of denosumab. But the whole data is in thousands, and having 11 or 12 cases, it's you can't make any sense out of it. Many a times we say that giant cell tumors, they have de novo conversion into malignant tumors. We also talk about giant cell tumors where we give drugs and they get converted into malignant transformation. And third factor is that at the beginning, there were giant cell sarcomas who were diagnosed at GCTs, and they were sarcomas to begin with. So I think with these very small numbers, it is extremely difficult to make any certain conclusion that whether denosumab leads to malignant transformation. To be very honest, I'm not really scared to administer denosumab at present because the numbers are pretty few, and globally it is not increasing. The patient in Tata Memorial Hospital had metastasis, and he died of the disease.
Okay, thank you, sir.
Thank you, Suman. And now the ball is in your court, and you will be entertaining us with some interesting cases where we can have a panel discussion, requesting all the speakers to interact, and maybe somebody, if you can invite Dr. Mandip Shah.
Thank you so much, sir. Yeah, thank you. I want, yes. So thank you so much. I think we are left with 30 to 40 minutes, but just now the MI match has ended and RCB match has not started. I think we will have more logins now, so we can take extra 10-15 minutes for discussion. So
is it raining, sir?
Is it raining? So we are not going to have the match. I don't think so.
Right.
So we have these few interesting cases. Let's take one by one. So she was a 25-year-old female. And today's topic is giant cell tumor. So we're not going into diagnosis. All these cases are biopsy proven giant cell tumor. So we are directly going into management. So that's the X-ray and MRI. So I'll just show a few other images. My question to Saggar, sir. Sir, you are there?
Yeah, I'm there.
Yes, sir. So 25-year-old female, biopsy proven giant cell tumor involving the proximal tibia. So what do you want to do here?
Yes. So this is a tumor which is eccentric, little extensile, going right up to the subchondral bone, and it is almost involving more than half of the proximal tibia and reaching up to the tibial spine. And in MRI, I don't see any effusion or anything like this. So probably this is a case which is a bit borderline case for curettage, but I will definitely give a serious thought to the curettage in this case.
Okay, so if curettage, whether you want to do upfront curettage or give any neoadjuvant therapy and then do.
Correct. Now, having said this, since I'm planning curettage, which is a bit difficult curettage in this case, because there's some breaks in the cortex, I might be having a very large amount of more than 50% of the articular cartilage getting exposed, and probably it might be a good idea to give a denosumab, maybe 2 doses or 3 doses within a month, and this let us see the response, and maybe then it may facilitate the curettage.
Okay, Dr. Akshay, your plan here?
My plan will be to, number one, of course, discuss with the patient pros and cons of resection and curettage. I will expect a little higher risk of recurrence here as compared to a regular curettage because of the large soft tissue component, loss of cortex. My personal practice has not been to use denosumab for preparing patients for curettage. So I'll, of course, my first choice will be a curettage upfront without any neoadjuvant therapy.
Quick comment, why not denosumab?
So my apprehension has been, and initially I did use denosumab in a few patients, is the higher risk of recurrence that I saw. I also believe that with denosumab, you ultimately end up curating or going back to the cortical level that you started with pre-denosumab. So that scenario, you ultimately have to reconstruct the cortex and the whole strut in one way or the other, whether you use a bone graft or a cement. And I know, particularly looking at the X-ray, I know that although there is some collapse of the medial condyle or the medial compartment of the joint, I still can, use either cement alone or a sandwich to reconstruct and keep the weight bearing a little delayed so that cortex forms all around.
Okay, thank you. So my next question to Dr. Ashish. So here there's you can see in the CT scan, there is break of the subchondral bone, means there's absolutely no subchondral bone at one point. So a lot of our orthopedician colleagues feel that if there is no subchondral bone, it is better to excise. So what is your thought and what is the practice and what do you want to do in this case?
So Suman, to be very honest, I'm not going to just rely on CT scan. I'm going to request for an MRI. I'm going to really assess the cartilage. Having no subchondral bone in GCT is pretty common, the kind of patients which we see. So that's okay. But what we need to see is whether there's any perforation in the cartilage or not, and whether there's intra-articular disease or not. If you have perforation in the cartilage and intra-articular disease, I would plan for a resection because this is not going to help in any ways. But if you do not have disease in the joint, if your cartilage is still intact, then I think in a young patient who has good range of motion, we can offer a curettage by properly explaining to the patient that rate of recurrence may be higher, but still, if we can save the joints, it's good for lifelong.
Upfront curettage, or you want to give denosumab?
Denosumab, definitely.
Okay. So how many dose and what is the interval?
I would give 2 denosumab on day 0 and day 15. Call the patient at day 30, look at the response. If not good, give 1 more, then wait for 1 month and again see the response. If I have just adequate response or an ossification where I feel that I'll be able to cure it well, I'm going to do that. And I completely agree with Akshay's point that sometimes not, in always and all the time, we have to go to the same margin, but it helps us to cure it at the periphery in a much better way. And this is where I feel the denosumab is quite helpful. And obviously it decreases the spillages.
Okay, Dr. Srinath, your comments, please.
I think I'll agree with Ashish sir. I would probably give a couple of doses of denosumab and then go ahead with the surgery. But my issue here would be about the main disease near the ACL footprint. So yeah.
What you're talking about, yeah. Okay, so everyone agrees that this case requires a chance that to save the joint after explaining the patient about the chance of local recurrence.
Suman, can I add something?
Yeah, please.
Like I will have 2-3 concerns. One is the loss of subchondral bone at some places, which has already been mentioned with the exposure of the floppy cartilage. Second is the tibial spine, where it is very close to the ACL. And thirdly will be the tibial tuberosity area, where it seems to be pretty close to the tendon. These are the 3 difficult areas. That is why the curettage is a bit difficult in this case, and that is why the denosumab comes in important, where it helps the curettage. Thank you.
Okay, so you can see in the MRI, so this cartilage is maintained over the medial side. Yes, there is no subchondral bone, but the cartilage is maintained. Even near the ACL attachment, this is maintained. So, sorry. Okay, so after doing a detailed discussion with the patient, the plan was done for curettage. Sorry, I just need to skip all these things. So in this case, as Dr. Akshay felt, even I am not using denosumab in the upfront curettage cases. I use only in cases where I am not able to use tourniquet, where there is a chance of bleeding, for example, in case of proximal humerus and pelvis. So in this case, yes, we went ahead, excised the biopsy scar, and that is the soft tissue component, which you can see here, that soft tissue has been excised. So we did a curettage. So after the extended curettage, that is how the cavity looks. And we used the autograft, used the iliac crust to support against the subchondral bone, and we use the strut graft to support the iliac crust here. So this is the intro of the cavity you can see here. So there is no cavity near in the anterior part, that's there. So there is no cartilage here. And so that's the part of the ACL here. So, but this is the anterior part, which is the non-weight bearing part. So we went ahead and did a reconstruction and curettage in this case. And you can see here with K wires, the graft is pretty stable here. So I have not used any plates. So that's the post-op X-ray. So this is the X-ray after, I think, 2.5 to 3 years. And that is the function of the patient. Focus. So we'll quickly go to our next case. So he is a 32-year-old male. Is a case of a recurrent giant cell tumor. He was operated at another hospital 6 months back, where curettage and autograft was done, and the patient had recurrence. So that's a X-ray and that's a MRI. So my question to Dr. Srinath. So it's a case of recurrent giant cell tumor of distal femur. So what do you want to do?
Was there a pathological fracture before the initial surgery, sir?
No. There is no pathological fractures.
No. Okay. So I think we can give it a trial of one more salvaging the joint and then try doing a curettage again.
Okay. So if you want MRI, I have the MRI here. So you can see a big posterior component, and that's the medial side, sorry, lateral side of the disease.
Yeah.
Okay. So again,
so I think
yeah, please.
Window on the lateral side excess the entire soft tissue component on the posterior aspect. I think we can curate the whole thing, put in a cement and then stabilize it with a plate or something. I think I would do that, and upfront, no denosumab.
Okay. So Akshay sir, so your opinion in this case?
Suman, I would also want to have a look at a CT. We know that the cortex is best seen on either CT or an X-ray. And I would agree with Srinath that I will still want to give curettage a chance, provided I don't see any intra-articular disease, any comminuted fracture, which I cannot reconstruct as far as the subchondral bone goes. As long as I can reconstruct a stable fracture, I will still want to give curettage a chance.
Okay. So Ashish sir, so you, Mandip Shah did mention that recurrent is not a contraindication to do a salvage. So what is your take on such cases? So you want to do salvage, or you want to excise, or how you are going to counsel the patient, and what is the recurrent rate in your hand or in TMH series?
So, Suman, thanks for the question. It's very important, and people need to understand that recurrence in giant cell tumor doesn't mean that it has become malignant. Recurrence in giant cell tumor doesn't mean that you can't recurate them again. The principles of treatment remains the same. You need to assess each case by at its merit. If you still feel that the recurrence is limited and you can curate it out, you still have an intact joint and cartilage. If you still have the remaining bone stock which can be reconstructed to have some functional limb and joint, then you must try to save the joint. And because even if it recurs again, you can sort of do the resection anyways. So principles remains the same, but yes, the chances of local recurrence will be pretty high because you don't know how much of contamination has happened in the previous surgery. And that's why we generally counsel the patient looking at the MRI, looking at the image, and usually it's more than 30 to 40%. But still, it's worth taking a chance and salvaging a joint in a young patient where the joint is intact and good range of motion is available.
Okay, so what is the recurrence percentage you want to give when you're counseling this patient?
It
If you
will,
want to try,
in this patient,
yeah.
anywhere between 25 to 30%, 35%.
Okay.
That's anybody's guess. But yes, I also agree with Dr. Srinath and Dr. Tiwari that there is adequate bone stock left, and we can do a curettage, and I will not give denosumab.
Okay. Saggar sir, so what is your take? Do you want a CT scan in this case? Are you happy with MRI, or do you want to give denosumab and then curette, or upfront curette, or your plan is to excise it?
Suman, for me, I really have to have a very careful look at all the possible images of on MRI, and because my concern will be definitely a posterior soft tissue mass. After curettage, there might be left a large periosteal sleeve there. And also, I understand there's not much intra-articular extension, but definitely, as Akshay did make a mention to, these are the cases where actually CT scan does help when you have a concern about what is the degree of bone stock left, so that we don't get surprises that it may not be a reconstructible cavity later on. So I want to be doubly sure. That means looking at all images of the MRI, and of course, looking at the CT scan pictures, so that I can plan the curettage if it is possible.
Okay. So Ashish sir, so whether you want to give denosumab or upfront curettage, or if you want to give denosumab, what are the prerequisites? What are the things you look before starting denosumab, and what are the blood parameters you need to monitor when you're giving denosumab?
So I already answered that in this patient, I'm not going to give denosumab. But if to answer your question for any other patient, denosumab, I'm going to make sure that there's no infection in the teeth. I'm going to make sure that vitamin D levels are adequate. If not, then give them supplementation. And also you need to make sure that you give additional calcium supplementation, and give denosumab to them as subcutaneous dose. Counsel the patient regarding the symptoms of hypercalcemia and to report back immediately. And this is how we do it.
Okay, so do you want to try zoledronic acid here? If no, why?
I'll just go, see, it's already messy in there. There are already grafts. There is adequate bone stock there. So I don't think so there is any use of giving zoledronic acid. I would like to go in as early as possible. But yes, if you are a very busy orthopedic oncosurgeon and you don't have time for next 2 to 3 months, then maybe just while waiting, I might give 1 or 2 injections of zoledronic acid and see.
Dr. Akshay, your experience with preoperative zoledronic acids in GCT, have you tried it, how it works, and what are the results like?
So I've not tried it as a strategy, but yeah, there have been occasions where others have given and I've had to cure it. The friability of the tissue is little less. I feel, I think that is the only difference, but doesn't usually ossify as good as it ossifies with the denosumab. In my limited experience, nothing of much of a change when you cure it after zoledronic acid.
Okay, thank you so much. So in this case, again, we did upfront curettage. So we did a big door there, as Dr. Mandip Shah mentioned, did an extended curettage. And so I used cement and plate for reconstruction in this case. So the patient, I think, is more than 3 years follow-up now. He is doing well. He got excellent knee function, and he is able to do all the activities. So now my next question to Dr. Srinath. So we know these cases have high chance of local recurrence. So would you like to give zoledronic acid or denosumab in this case? And if yes, why? And if no, why?
I would not want to give zoledronic acid or denosumab, because if we start something like that, it needs to go on forever. So instead of starting something like that, maybe we can just wait out, see if the patient has a recurrence. Then if you can't cure it, then maybe go ahead, do a resection and make the patient disease-free. Because if you start any form of adjuvant, that needs to go on lifelong, and then we don't know how the patient would behave after a few months. So we don't have data to say what will happen if we give long-term denosumab.
Okay, Dr. Saggar, your take on adjuvant zoledronic acid or denosumab, whether it works, doesn't work, whether you practice in your daily practice or you don't give.
Yeah, good question, Suman. I don't use at all as a post-operative usage of these zoledronic acid denosumab to prevent the recurrence, because it's primarily a surgical disease. It's not a bailout, that it can prevent the recurrence. Definitely no role here. It has mainly a neoadjuvant role, or as Dr. Gulia mentioned, about the unresectable or metastatic settings, not as a post-operative adjuvant setting, not at all.
Ashish sir, what data says about post-operative denosumab? Is there any data? Is there any role of giving it?
Hong Kong group, Dr. Kumta and Casey Wong have tried this, and they have shown that there is a decrease in the recurrence, but I don't think so it has been replicated anywhere else globally. So I think that I'm not really sure about it. We don't use it, and whatever the data has come, it has come in very, very small tumors. They pick up tumors pretty early, and where anyways the recurrence rates are pretty less. So we do not have any robust data to support that post curettage denosumab or post curettage zoledronic acid has any substantial role.
Dr. Akshay, your take?
I've not generally used either denosumab or bisphosphonates in the adjuvant setting. Logically, we know that denosumab is not cidal for tumor cells. There's no logic using denosumab, because we know even in active disease, it just works as long as it is given. As far as bisphosphonates go, I know there is some preliminary data suggesting adjuvant use, but yes, there's nothing robust on which we can fall back upon. So no adjuvant therapy in my practice.
Okay. Dr. Akshay, one more question to you. So in this case, you spoke about reconstruction with the cement, graft or sandwich technique. So young patient, disease going up to the subchondral bone. So what would you have done in this case, and why?
So that was precisely, I was actually wanting to ask you the reason that you used graft in the previous case and cement again. But now that you've asked me, I think I would have used cement as you did, because there's no way I can use autologous bone graft, which is the only bone graft I have got access to reconstruct the cartilage, keep it in place and stabilize the fracture. So I think in my practice, I would have used cement and plate as you did. But my question is that what made you choose graft in the previous case and cement in this case?
Sir, what I do is in recurrence cases where I know the chance of recurrence is more, I would prefer to use a cement, mainly for it's a reason like we can early detect it and we can treat it as early as possible. So that's the reason I used it. And usually when I'm counseling the patient, I'll give them both the option and I'll tell them the advantages and disadvantages. And it also depends upon the patient choice, what they select.
So in my practice, I've seen the moment you offer both, cement has got, huge advantages. You can make them walk earlier. Rehabilitation is faster. They don't need another incision. Surgical time is shorter. So there's everything that goes for cement as against a bone graft. So generally you have to have a very, valid reason to opt for bone graft as long as it's an autologous graft that you have going to harvest from the patient. So that has been my experience. I would have probably used cement both in this case and the previous case for the reasons that I just mentioned.
Sir, actually, we have allograft facility here. So that's one advantage we have here. But I want to hear from Dr. Ashish. So in TMH, what you would prefer, whether doing a cement or a bone graft, and what are the advantages you have found?
So TMH has seen a sea phase change in last 2 decades. Initially, it was all bone, 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 bone. Then came sandwich. Then we started with cement. And then, all the data about cement came. So today, whatever you put, it's fine. It's absolutely okay. I agree with Akshay that it's so easy to use cement. It decreases your surgical time. It avoids incision. It's quick to do. You don't need a bone bank. But yes, because we had bone, we were using a lot of bones, which is not bad either. But cement has few advantages. Like for example, in this case, I will definitely use cement. As you rightly said, the chances of recurrence is higher. And if still have to salvage the joint, you pick the recurrence up pretty early. So that's one very important advantage. Second is that with cement, you can actually reconstruct the cavity even with a very small bone stock left. And it gives you a rigid fixation and it maintains the joint line. So that's another advantage with cement. But having said that, once you've used that, then any sort of recurrence happening, you will have to definitely excise it. So the only changing point or the tipping point for me is the age of the patient. If the patient is pretty young, I would tend to use bone, especially in primary cases. If not, then I think most of the cases, cement is the preferred one.
So thank you so much. So we'll move on to our next case. So she was a 23-year-old female. Sorry, I have only these two images. Biopsy proven giant cell tumor, which is involving the anterior column of the acetabulum, and disease is extending into the mid superior rami. So my question to Srinath, so what do you want to do? 23-year-old female giant cell tumor involving the acetabulum.
So this is a tricky thing actually, because
that's why he's asking the expert.
So you can either do a. So I think probably, given the age of the patient, I would offer them denosumab and then curettage, or maybe definitive denosumab, because it's in the acetabulum, and then resection would be quite morbid. So I would give denosumab and curette and give it a try of saving the joint, or give definitive denosumab long-term therapy.
Okay. Saggar sir, your take?
Suman, for this particular case, I will definitely think about denosumab and curettage. The reason for me to think about curettage is because I do see a nice shell on this picture saving the joint, and probably it should be possible to curettage. Yes, denosumab will help me to reconstruct the quadrilateral plate side of this lesion, and that will help me in the curettage. Probably it's a good idea. I will think of curettage actually.
Akshay sir?
Not a lifelong denosumab. I mean, that's a bit guarded here.
Okay. Akshay sir?
I would discuss curettage versus resection, because I can still save the supraacetabular part and still have some stability there. And if it's resection, then it will be following denosumab. If it's curettage, it will be upfront for me.
Okay, so what is the downsides of doing a curettage in this case? Or why you want to consider excision?
It's just that the risk of recurrence is a little higher, in fact significantly higher than an extremity GCT.
Okay.
If I were to choose for myself, I think curettage would be the first choice, because section still remains an option after a recurrence.
You would consider definitive denosumab here?
Not as an upfront strategy. A patient who has had multiple recurrences, or a patient who's just not willing for any kind of surgery, definitive denosumab will be reserved only for those patients.
Ashish sir, your take.
Somewhere a middle path regime, give denosumab, do a resection curettage. So I don't know if I can mark it. No, I'm not able to mark it here.
Yeah, if you can next time try to mark it.
Can you see it now?
Yeah, this yellow line, sorry, green line. Yeah.
Yes. So this is the disease extent, and this is the disease extent here, like this. So what I'm going to do is, I'm going to resect it somewhere like this, so that I have a clear margin. I'm going to go intralesionally here like this, take this out, and then I'll be left with very small part which is near the dome. So here the dome is intact. So I'm going to save the dome. And in this part, I'm going to do a curettage. I'm going to take a tricortical graft from here and get that graft down there and reconstruct the medial wall. This is what I will do.
Actually, when I was in TMH, like maybe in the pre-denosumab era, we used to use angioembolization. So, still you prefer angioembolization in this case, or you want to use denosumab?
So if I'm going upfront, I'm not going, then definitely I'm going to use angioembolization. But if I'm using denosumab, then I don't think so we need angioembolization because denosumab decreases the vascularity of the tumor dramatically.
Okay. So that's what done in this case. I gave her 2 injections of denosumab. So denosumab, we know that it makes tumor little hard. It reduces the spillage in that area. And second, it reduces the vascularity of the tumor. So you have a clear field to operate, especially in these cases where we can't use tourniquet. So 2 denosumab was given to this patient. Sorry, I don't have intra picture. So exactly same was done. The superior rami was excised completely. So that is the floor of the acetabulum where we did extended curettage. With the same incision extending upward, I took a ilia crust graft, placed it and put a screw. So it's been, I think, more than 2.5 to 3 years. So she is doing absolutely fine. There is no restrictions at all.
Suman, you gave denosumab here, right? Did you?
Yes, I gave 2 injections of denosumab. Yeah.
And what was the response like?
Sir, usually when I give denosumab, I give the main intent was to reduce the vascularity. So I really don't wait for the X-ray response. So I give first 0 and next 7 days, and usually I operate after 2 to 3 weeks.
So usually you will get response in that time, and you will get a shell in about 3 to 4 weeks time.
So that was the procedure, and she. Sorry, by the way. Okay, so she had a normal delivery after that. So there was no issue with the pelvic cavity. So it's been more than, I think, 3 to 4 years of follow-up. Okay, so next case, a 16-year-old giant cell tumor of the patella, which was operated outside, and she had recurrence now. So this is her patella. So that's a lesion. So Dr. Akshay, 16-year-old giant cell tumor of patella. So what you want to do, I'll just show you the MRI images. So these are the MRI images of the patient.
So again, discuss with the patient. For me, it will be a total patelectomy.
Okay. Dr. Srinath?
On the MR images, at least the articular surface looks okay. So I think probably I'll give it a file of curettage and then fill it with bone graft and see how it works.
Okay, Ashish sir?
We have discussed this patient earlier, and my answer remains the same. I'm not a very big proponent of doing curettage in patella. One of the cases you might get away, but it's an extremely, extremely difficult bone to do the curettage. Especially when I see these images, in the axial section, you have disease right till in the end. So according to me, it will be very, very difficult to curate that out. And I also see some break in the cartilage in the sag cuts. So for me, it's a patelectomy, VY-plasty, reinforcing of the quadriceps mechanism. And I have done quite a few, 3-4 cases, and almost everybody has full extension. So I'm pretty happy with that. I'm not going to sort of, I can offer both, but for me, in my hands at least, the recurrence rate is going to be pretty high, and I'll be very worried about it.
Okay, Dr. Saggar, your comment?
Yeah, regarding the patellar tumors, in this particular case, I see this patella has been fiddled before. Number one. Second, it's the tumor has grown. It's quite large expansile, and these will be the major reasons for me to think about resection. That is total patelectomy, Having said this, the only patellar tumors were actually for GCT. I mean, I'll be much more aggressive for patella rather than, yeah, had it been a very small lesion, then it would have been a different story. But yes, in this particular case, I'll go in for the section.
Okay. So here, the only thing is patient had some family issues, so we couldn't do upfront surgery. We had to give 2 doses of denosumab. She responded well. The pain had come down. So only thing is here we attempted curettage because we know that even if it recurs, we could go and excise the patella. So we wanted to give a chance to a 16-year-old young patient. So what we did in this case is we went ahead. So took out the complete anterior surface of the patella. You can see the post denosumab. There will be so much fibrosis in the tumor. Will be pretty hard. So spent almost 2 hours to get this surface. Then we had this allo patella available. Luckily, one of our patient where I had done amputation had given this allo patella. So I used the same patella and drilled multiple holes, and with ethibond we sutured it. So that is intraoperatively, it was pretty stable up to 20 to 30 degrees. It was not getting subluxated. So this is the follow-up of the patient. It's been 6 months. So she is doing pretty well. We are having a close watch on her. So we'll update the follow-up in the future conferences.
Suman, can I say something?
Yeah.
I mean, if this case comes to, I mean, you've got an excellent result, honestly. I mean, you're doing well here. But is the message?
He always does well, sir.
I know. I mean,
Thank
you for correcting me. But you know, for as simple as total patelectomy, curable, and on the other side, you're doing a denosumab extended curettage and followed by allografts. I mean, is this the message that this gives better results than total patelectomy? And what is your take on this, Suman? You got a good result in this. Will you do this procedure again if any other patient comes to you?
Sir, 100%, because I know that if it recurs, it will require simple patelectomy. It won't be much complex surgery. So I would like to give a chance. But yes, we will have a follow-up of this patient. So I'll get to learn from this case also.
Okay. Thank you.
So we'll quickly move on to the next case. 32-year-old.
Suman, I think it's quickly we have to wrap it up.
Okay. So a 32-year-old Grade Campanacci giant cell tumor of distal radius. So from each one, if you can quickly comment what has to be done, so we'll take it further. Srinath.
A resection and missed arthrodesis here, probably with an iliac resport.
Okay. Akshay sir.
Resection and radialization of Anup.
Okay. Saggar sir.
Resection and single bone forearm, ulnar translocation.
Okay. Ashish sir.
Agree with all.
Okay. So my question is, when in distal radius GCTs, I know the recurrence rate will be recurrent is much higher than other location. So what any particular criteria, or how you decide whether to do a curettage or excision in this case? What are the criteria you take into consideration before deciding to curette or excise?
Suman, who are you asking?
You can answer, sir.
Okay. So generally the criteria will not change. They will remain the same. But what will remain as part of our counseling is that this is a location where the risk of recurrence is higher than other locations. And this is also a location where reconstruction after a resection gives a better results than as compared to, say, a knee joint or an elbow joint. So these are two things which keeps a threshold for resection arthrodesis lower than other locations. That is
my question to Ashish sir: why you want to do arthrodesis? Why not fibula? Is there any difference in the outcome, and is there any literature to support it?
I extensively read about doing a fibular arthroplasty. Have few colleagues in India who do that, but I've not been able to dare to do it, and I've not been able to have the results which are as good as doing wrist arthrodesis, either with an iliac crust or with translocating the ulna radially. So I don't know why should I change. And every patient of mine, whether they are laborer, whether they are software engineers, whether they are drivers, whether they are swimmers, everybody has adapted so well to this arthrodesis that nobody has come back to me and complained that, I've lost this motion. Can you restore it? The only problem which I have faced in long-term follow-up is from females who says that my wrist looks pretty small as compared to other, and this is where we started doing iliac crest bone grafting for females. But otherwise, it has worked wonders. Dr. Tuli's series, which I heard in one of the IOA con long back, he's got like 18 to 20 years follow-up of these patients, and almost 85 to 88% of the patients had issues and underwent multiple revision surgeries. So I really don't think so. I would be doing a procedure which has high failure rate just because in the initial phase I want to show that I have restored movement. In addition, you need to do a second incision. There is an issues about peroneal nerve palsy. There are issues about morbidity to the donor site. So and I mean, globally, it is known that it subluxates and leads to secondary arthritis. So I don't see any reason why I should change my practice.
Can I add something, Suman?
Yeah, please, please.
See, when I started my career, I mean, I was not aware of doing ulnar translocations. It came pretty late when the team from Tata came up with the recommendations. I used to do as a fibular arthroplasty in the initial 5-7 years. And all those patients on follow-up, they all had significant deformities, significant limitation of the movements, significant limitation of even the grip strength, and a real cosmetic disability was there. And as Dr. Gulia did mention, there were a lot of issues related to stabilization and sometimes K-wiring and all those things. I mean, there was no other option. I mean, this procedure was not understood at that time till the ulnar translocation came. Now, after doing these procedures with the arthrodesis, as Dr. Gulia did make a mention, the patient satisfaction rate has gone pretty high. Even if the width of the wrist, which Dr. Gulia did make a mention, I mean, I noticed when you put it with the third metacarpal, even that is not much significant as compared to doing another second. So I think now the fibular arthroplasty is not being done anymore.
Okay, thank you. Thank you, sir. So we'll just go ahead. So this is the MRI of the patient. So this case was taken by one of my friend. So where I think both the options was given and patient wanted to try a chance of curettage. So curettage has been done in this case with a good outcome in the 4 to 5 years. But we always know that the recurrence chance is quite high in distal radius. So we need to counsel the patient well before doing any procedure. So this one more case, there's a huge recurrent giant cell tumor where the tumor has been excised completely and wrist arthrodesis has been done. You can see the patient having a good functional outcome. So coming to distal radius GCT, they have very high chance of recurrence. So usually we use Cheng's criteria to plan our excision or curettage. If any of these two are present, we prefer to do an excision, like tumor invading the articular cartilage, destroying more than 50% of the cortex, or if there is a soft tissue component in more than 2 planes. So as we discussed, there are options we can do arthroplasty with fibula graft, or you can do arthrodesis with just shifting the ulna to neighbor bone. So that it has shown that a stable joint gives a better outcome than the arthroplasty. So thank you so much. I like to end our case discussion here.
Thank you so much, Suman. It was pretty interesting, and you have shown GCTs at various sites and involving various kind of treatments. If you could stop the screen share, then maybe I'll just end the session. Thank you so much. And while concluding, I would reiterate again that the Indian Orthopedic Association has been supporting to promote orthopedic oncology in a big way. And once again, on behalf of oncology subcommittee, I thank the IOA administration for the same. My sincere thanks to Dr. Srinath Gupta, Dr. Mandip Shah, Dr. Tiwari, Dr. Saggar, and Dr. Byregowda for their time, for planning of this webinar and contribution. My sincere thanks to each and everyone who has joined us and who may be listening to us a bit later for this webinar. And I have sincere request to all of you that let's come together and uplift the standards of orthopedic oncology in our country. And that can only happen if we educate our juniors well and well in time during their post-graduation. So please support the various academic activities which are done by Sarcoma Education Foundation, Indian Musculoskeletal Oncology Society, and IOA, and various other education societies to help our juniors learn the right thing in the right way. So thank you so much for your contribution. Thank you.
Thank you, Ashish. It was a pleasure.
Thank you, everybody.
Thank you. Thank you so much. See you soon.
Thank you.